No worries.
Welcome, Michael. Thank you to the session on Tics and Tourettes with Future in Mind today.
My pleasure. Right, let me just try and share screen. There we go. Right, just to confirm, can you see the screen?
With notes.
With notes. That didn't work very well. And of course, it's happening as we go. So try that. What can you see now?
With notes.
Oh, okay. And of course, it's all happening whilst going. So let me just close that down. Right, then.
That's better.
Bear with.
Oh,
right. Is that better?
Yes, that's better.
Finally.
Right.
And without my usual flap. So apologies for that little delay, technical problems as per usual. So thank you for joining me today. My name is Michael Rolt. I'm one of the clinical psychologists at Hampshire CAMHS and doing a short workshop today on tics and Tourette's. Hopefully you'll find it useful. If I'm unclear in any way, or if you have any questions, can I ask you to put them in the chat box? I've allocated time at the end, and I will go through as many of them as I possibly can. So, 3 things that I want you to take away from today is I want you to have I guess, a better understanding what tics are and what Tourette's syndrome is, an overview of the treatment pathway, and then strategies that help manage tics. And these are strategies from both the perspective of school, but also as parents, what we can do to help. So first thing really is a definition of what is a tic. So tics, according to the American Psychiatric Association, is a sudden, repetitive, non-rhythmic motor movement or vocalization involving discrete muscle groups. So these, as described, are sudden, brief, they're intermittent. It's the hallmark of Tourette's syndrome. They can range from being mild to severe. Severe symptoms might significantly interfere with communication, with daily functioning, with quality of life. They involve, as it says there, motor tics, which is movement, sounds, which are vocal tics. Motor tics generally start off first, followed by vocal tics. However, there is a really broad spectrum of tics, and the people that experience them is diverse. They can vary in type, in frequency, severity. Some can worsen when you're feeling ill or stressed or anxious, tired or excited. They can often occur during sleep. They can change very much over time. So you may get peaks in presentation followed by lulls. They tend to worsen in early teenage years and improve as young people transition into adulthood. They can also be consciously suppressed. However, this does take a toll on the body and can be quite tiring for the young person. So clinical characteristics, as I mentioned, there are motor and vocal tics, and we classify these even further into simple and complex. Simple are very brief, repetitive tics from a limited number of muscle groups. So for the motor tics, the muscle movement tics, often we'll see eye blinking, head jerks with these rapid movements of the head, hand movements, so it could be clenching, fists, stretching, leg movements, again, could be stretched, could be flexing the any part of the leg. And then the vocal tics, the simple ones, are more about uttering sounds. It could be sniffing noises, animal or bird noises, coughing. And then we have the more complex tics. So these are distinct, but they're well coordinated patterns of movement involving many different muscle groups. So these could be whole shoulder movements, engaging neck, shoulder, arms, facial expressions, complex facial expressions, the body bending, copopraxia. So this is involuntarily performing obscene or forbidden gestures that have no control over by the young person. You can have whole head gestures. And then from vocal tics, the more complex ones involve whole syllables or whole words. Coprolalia, which is using involuntary swearing in socially inappropriate situations or derogatory remarks. Coprolalia, I guess, in the media is something that's people come to associate with tics, but actually they're relatively rare, and actually only 1 or 2 in 10 people with Tourette's experience coprolalia. And then other 2 are echolalia, which is where you repeat what other people have said directly after they say it, or palalia is where you repeat your own words after you've said it. So what do you need to exhibit to have a diagnosis of Tourette's? So you need to have 2 or more motor tics and at least 1 vocal tic. Now those tics may change over time, but that's the basic consideration. Those tics would have lasted for at least 1 year, so 12 months. And they had to have begun before the age of 18. Most tics tend to start in sort of the early teens or before. Rarely do they begin after the age of 18. And the symptoms, the ticking, has to be ruled out. They're not due to taking medication or other drugs or due to having any other medication. So it's really important to rule out any physical health presentations. Now, we do see ticking in other presentations outside of Tourette's, and they're called stereotypies. And these are the types of presentations where stereotypies occur. So they can occur in autism, young people with intellectual disability, where there's been an element of sensory deprivation. These tic-like stereotypies can be found in certain genetic syndromes, fetal alcohol exposure, stroke or brain injury, or any difficulties with the brain structure itself. So these stereotypies look like tics that you find in Tourette's. So they're repetitive movements or sounds, and they can be sort of body rocking, head nodding, finger tapping, or more complex movements such as moving your arm or hand flapping, waving or pacing up and down. But when it comes to Tourette's, we really don't know what's caused it, but we think that there are some genetic components interacting with the environment. These genetic components, again, we're not really sure. There has been no gene identified with regards to this. What we do know is there are some risk factors that have already been identified. So this is things like if there is a family history of Tourette's, then that increases the chances of developing Tourette's syndrome. And also males. Males are 3 to 4 times more likely to develop Tourette's than females. Okay, so let's think about when tics typically emerge. So, as I say, mainly young boys between the ages of 5 and 8 years old, and it tends to affect 12 to 18 to 20% of the school-age population. So it is a large minority. And what tends to happen is once the tics have established, it tends to peak during puberty, but then decreases over the second decade of life. And then over time, the tics become more suppressible. So what we find is that as people's executive functioning, their ability to have control over their functioning better, tics themselves become more suppressible. So they become less impairing over time. Now, how we like to think about Tourette's syndrome, I'll use the analogy of the iceberg. So it describes that tics itself is really complex and very varied. So like an iceberg, only a small proportion of Tourette syndrome symptoms are visible to the outside observer. And the majority of the difficulties remain beneath the surface. So the visible symptoms are your motor and the verbal tics. However, this iceberg, as it suggests, that there are many other symptoms associated with the Tourette's that aren't immediately apparent. They're under the water. So these include sensory processing difficulties. They can be associated with anxiety, low mood, obsessional compulsive disorders behaviors, ADHD, sleep disorders, and other related conditions. So this iceberg, this image serves as a reminder that people with Tourette's may experience a wide range of challenges beyond just those visible tics. It also highlights the importance of recognizing and addressing other symptoms and not just the tics to provide the best possible care for the young person. Okay, so it's more than just a movement disorder. So we use the term Tourette syndrome as a syndrome of difficulties. And we better understand it rather than just a movement disorder. It's a real complex neurobehavioral condition. And that associated with Tourette's, when you're working with young people, you're always keeping an eye out for other types of mental health difficulties and behavioral difficulties. Okay, so thinking about young people who have a diagnosis of Tourette's, 86% also have a diagnosed with at least one other mental, behavioral, or developmental condition. And most commonly, so we have ADHD, so up to 60% of young people with ADHD can experience a diagnosis with Tourette's. Obsessional compulsive disorder or behaviors up to 40%. Anxiety disorders up to 30%. Conduct and oppositional defiant disorders, so those more refusal type behaviors, or conduct disorders is where you're involved in perhaps more antisocial type behaviors. Up to 30% of young people have Tourette's. And then autism spectrum condition, around about 5%. So as you can see, there's a lot of what we call comorbidity, where someone has a diagnosis of one condition, also having a diagnosis with another. And then specific learning difficulties, up to 23% have Tourette's. So thinking about the treatment pathway, I work within Hampshire CAMHS. I'll talk about this a little bit later on, but there is no national guidance to the supply of support for tics and Tourette's across the UK. And so we're reliant on local resourcing to pull these treatment pathways together. How it is proposed to work is with regards to what we call a neuro screen, or a physical health screening with the GP is the first logical step. Why that's important is, if you remember me talking about the stereotypies, these are conditions where tic-like behaviors occur, but they're not associated with Tourette syndrome. What's important is that a physical health screen is conducted to see whether or not any of these other physical health conditions might explain the Tourette's, might explain the ticking. This includes, are they on any medication associated with ticking behaviors? Once a neuro screen's been completed and ruled out any of these other physical health conditions, if the presentation of tics is mild, i.e. it doesn't cause huge amounts of impairment or interference with their life, if it doesn't cause significant amounts of distress, if it comes and goes and lots of variability, we would consider that a mild presentation. So what the GP should be doing is providing some basic psychoeducation and referring through to support organisations. However, if the presentation is more severe, and we would classify it as a moderate or severe presentation, then it would be appropriate to refer into CAMHS. The first component of that would be psychoeducation for the young person and the parent. Now, the other, and this is much rarer, is if there are what we call physical health red flags, if there are some suspected physical health causation for the tics, then the GP may refer into a neurological service or pediatrics for a full review. Once inside CAMHS, the pathway would be for more moderate presentations. We would do something called CBIT, and I'll talk about that in a little bit. But depending on what the biggest priority is, we may treat the comorbidity. So we may be looking at anxiety or depression. We may put them through for an ADHD assessment. So depending on what the key need is, we would focus on one of them first. In cases where psychoeducation and the intervention isn't successful, for the more severe cases, medication is indicated. In cases where medication isn't indicated, we would refer through to a more specialized child placement. So hopefully that gives an indication of who is responsible for supporting a young person given the situation. Mild symptoms are supported by the support organizations, and I'll talk about a few of them in a bit. The moderate to severe would be a CAMHS. Unless they're very treatment resistant, we would escalate to a tier 4. And then for those where there's a physical health potential underlying it, then there's a neurological or pediatrics. So from a CAMHS perspective, how we would look at the tics and Tourette's, we would do a very detailed developmental history. We would formulate, it's really important to understand what triggers cause the young person to tic more, but also what are the consequences to them ticking? How do people react? Because those factors are really key. It's those environmental factors that are really key in maintaining tics. And then there's the intervention itself. Now, psychoeducation itself is a really, really good intervention. And actually understanding helps to destigmatize and help your understanding of it. But then there's the actual active component, the habit reversal therapy. And in this case, it's something called CBIT, which is a comprehensive behavioral intervention. I don't want to necessarily go into too much detail, as I do want to focus a little bit more on support that can be done at home and school. But I think it's really important that we just have an overview of what an active treatment for tics looks like. So when we're formulating, although we know that tics have a neurological basis, we know that the environment plays a really significant role in expressing tics. So for example, external cues. So these can be specific activities that influence whether or not tics are more likely to manifest. So these activities could be playing sports or playing musical instruments, or they could be specific situations, specific contexts. So for example, returning home, it may have been noted that actually tics more likely to be expressed, or with specific family members. So these are external cues, things that you do or think, places there you are that influence the maintenance. And it's really important that a young person and their family understand where tics are more likely to be expressed, or indeed in situations where they're less likely to be expressed, because that helps develop an individualized treatment pathway. And then there are internal cues. There's something called premonitory urges, which I'll talk about in a little bit, but also understanding those mood states where you're more likely to express tics. So this could be maybe in situations where you feel anxious, or maybe situations where you feel bored. So it's really important to understand how the environment impacts on you and maintains tics. So I've just got some research here. This is me because I'm a bit of a nerd. So what has been found is that being upset or anxious tends to be associated in most individuals with an increase in tic activity. Watching TV or playing games, remarkably, there's a 90%, that's 90% of young people who watch TV or play games report a higher incidence of tics. So just watching TV and playing games has a massive impact. Being alone, being bored, social gatherings, stressful life events, hearing other people's cough has been associated with increasing people's tics. And just talking about tics, so talking about tics with other people. When I work therapeutically with young people who have tics, you can see when they're discussing the tics, you can see them ticking more. So often young people can be really concerned about whether or not they want to be talking about tics because they feel the distress associated with ticking more, and they want to keep it as infrequent as possible. So it can interfere with the therapeutic process itself. But I like to be clear with the young people that it's really important that we actually talk about these things. And actually, in understanding tics, if I can understand them better, it means I can support them better. So thinking about what makes a tic, and it's not just the movement. I mentioned something about an internal cue called a premonitory urge. That's a sensation. It's some people describe it as like a special itch. That feeling you have just before you sneeze, that's kind of a premonitory urge. Or when I work with clinicians in training them to work with tics, one of the exercises I do is if you open your eyes and keep them open, if it's comfortable to do so, that feeling that you get to blink is the closest I can think of what it feels like to have a premonitory urge. So you have that feeling. Now that's quite an aversive, it's quite an unpleasant feeling. And what people with Tourette's do is they learn that by performing the tic, you relieve that uncomfortable feeling. So you get a sense of relief. Now, there's something called negative reinforcement. So a type of psychological behavioralism, and it's very much involved in habit forming. So you learn that by performing the tic, you get relief from this uncomfortable premonitory urge. Now, the more that you learn that, the more likely you are to do the tic, because the tic itself is really, really good at getting rid of that premonitory urge. So the more you do it, the more your body learns that it provides relief. So you're more likely to do it in the future. So that is kind of how the cycle of the habit begins. You have the uncomfortable premonitory urge. You perform the tic to extinguish that urge. You get relief from that. The body learns that actually, if I feel that urge again, I'm going to do the tic because I know it works really well. And so it becomes a habit over time. And it's really important as part of the work that I do is that young people understand and are aware of their premonitory urge, because how it works is that once you're more aware of those urges, you can decide to do something different than performing the tic. So the premonitory urge is this strong feeling before a tic. And these sensations are only relieved after the tic has been carried out. The tic itself, you can control the tics for a certain amount of time in certain social situations. But it's really, really tiring, and a person may have a sudden release of tics after the end of a day of controlling. I work with so many young people where they spend so much time and effort suppressing those tics during the school day. And as soon as they're out the school door, on their way home, they have this burst, often labeling them as a tic attack. And this is where it's rebounding after that day's worth of suppression. And they will often articulate just how tiring it is to suppress those tics. when speaking to the young people why they suppress them, you won't be surprised to hear that it's because they don't want to attract attention, or maybe the teachers themselves tell them off for doing tics. So there's a whole range of reasons why they want to suppress them, but there's often a rebound effect when they get home. So families and parents will often report this massive upswing of tics at home that they don't necessarily report at school. School may be completely oblivious to these tics occurring because they've been suppressed so successfully. So what we do as part of habit reversals training is something called a competing response. And when young people are more aware of this special itch, this premonitory urge, you can then implement a intervention to prevent the occurrence of the tics by doing something different. So this is the normal process. You have a premonitory urge. You've learned through a process of habit forming that the tic works. What a competing response is that once you feel the premonitory urge, you mindfully, consciously do a competing response instead. So what does this competing response look like? Well, a good competing response is the opposite of the tic. It blocks the tic. It prevents you from doing the tic. It's less of a problem than the tic itself. So you'll do a behavior, but it is less, I guess, attention attracting. It's less distressing for the young person. It's less noticeable, or maybe less painful than the tic itself. And you can do it for at least a minute or until the urge for the tic passes. So a couple of examples I can do is I often work with young people who have a neck tic where there's a neck stretching. So they have the premonitory urge, which will be like a tensing of the muscles in the neck, and they sort of stretch in either direction to extinguish that uncomfortable tension. So what you do is once they feel that premonitory urge, is you get them to do a movement in the opposite direction. So if someone has a tic that means that they fold their head back, you can get them to, once they're aware of that tension, and usually it's in the back of the neck, you would get them to very gently move the head forward a little. So it's certainly not as distracting or noticeable as the original tic, but actually what you're doing is challenging the response of the tic, and just holding your neck still, maybe a little bit down, you can feel the tension throughout the neck. And actually, if it can take less than a minute, that urge disappears. And it disappears without having to do the tic. And the benefit is, it's not as noticeable. You don't often get the reactions that you do with the other tic. And then they can get on with what they're doing. So that's basically what competing response training does. Now, there are challenges to treatment pathways. I mentioned before, now, I don't know whether you're aware who NICE are. If you don't, NICE stands for the National Institute of Health and Care Excellence. It's a governing body of treatment development. So knowledge is compiled by experts, service users, carers, and the public, and it recommends appropriate treatment and care of people with conditions in the NHS in England and Wales. So most of the challenges young people face, such as ADHD or autism, anxiety and depression, we've had NICE guidelines for many, many years. And that means there's a consistency of approach to how to treat young people with these difficulties. However, there are no such guidelines for tic or Tourette's syndrome. And this is a great shame, but it actually mirrors the fact that there's much less research funded and carried out on Tourette's syndrome than other conditions. But without these national guidelines, there is much less consistency on the referral pathways and a lot more pressure put on local teams and services to develop their own. And the other challenge with tics and Tourette's is this a physical health problem or is it a mental health problem? It's kind of sitting in the middle somewhere. So it's a complex neurological problem, but it could be maintained by physical health, these stereotypes, but then it also could be more of a behavioral mental health difficulty. So because there is this confusion, because there are no guidelines, young people get stuck bouncing between services, which is absolutely unacceptable. So some GPs may refer young people directly to CAMHS or send on to pediatrics if a young person presents with tics. Without a physical health screening, CAMHS will often bounce back to a GP or pediatrics if a physical health screening hasn't been done. So you can see young people can be passed between services, which is distressing and frustrating for families and delays the young person getting appropriate treatment. But hopefully with the definition of our local pathway and in agreement with our colleagues in GP services and pediatrics, we can reduce some of these delays. So thinking about what can we do in the meantime. So these are strategies that help develop tics, and I am mindful of the time, but I will try and be as succinct as I can whilst being useful. So for example, thinking about strategies. So this is open communication. So it's really, really important to encourage the young person to talk about their tics. Create a safe space for open discussions without judgment, to listen and empathize with their experiences. It's incredibly important to destigmatize, to humanize these experiences so that the young person feels less shame, less anxiety about it. They may struggle to begin with to talk about tics because they know they express their tics more in those situations. But what's more important is they're able to talk about their experiences. Collaborating with professionals. So these are professionals like healthcare professionals, GPs, pediatrics, neurologists, consulting with third sector organizations like Tourette's Action. I'll go through a few more in a bit. Seeking guidance from teachers and schools to create a more supportive environment, and exploring therapy options or medication when those opportunities arise. Developing coping strategies. So these might include relaxation techniques to manage stress, to identify and practice diversion techniques, redirecting attention during tic episodes. Basic healthy lifestyle habits that we all should do and perhaps don't do as much as we should, but they have a real impact on tics. So this is as much as possible encouraging a healthy lifestyle, regular exercise, balanced diet, adequate sleep. These all have really positive impacts on well-being, but also a beneficial impact on tic management. Regular exercise is particularly important because when young people engage in exercise, the amount of tic severity reduces during the exercise, but also for a short time after. So it's really, really good in not only maintaining well-being, but also reducing tics in general. And sleep as well is incredibly important. The more tired people can become, the less they are able to suppress or control tics. So actually getting a balanced sleep hygiene is really, really important. And then promoting self-advocacy. So as they get older, encouraging them to understand their condition a bit more and advocate for themselves, teach them how to explain Tourette's to others, to communicate their needs more effectively. So it's kind of training them up, building them up to be more resilient. And then celebrating achievements. So this is really important anyway, but celebrating achievements big and small. This sort of positive reinforcement, boosting their self-esteem, and that can help them navigate the challenges associated with Tourette's. And then encouraging relaxation techniques. I probably don't have enough time to go through it, but you've probably seen lots of these already. So there is an association with anxiety and stress and tics. if they become more resilient and self-agency, is things like triangle breathing, guided breathing, progressive muscle relaxation. Lots and lots of resources on the Hampshire CAMHS website, on YouTube. Just being able to tap into resources as and when they need them can be incredibly important for a young person. And it builds up their ability to understand that actually I can manage these situations better, the ones that are associated with more tics. So creating a supportive environment. So for example, this would be education and awareness. So this is yourselves learning about tics and Tourette's, to educate family members, family friends, and teachers about tics, promoting an understanding of tics to reduce stigma and misconceptions, to reduce the prevalence of negative responses to people ticking, and fostering an inclusive environment that encourages acceptance within the family unit, within friends, within schools. Positive reinforcement. So this is, again, celebrating achievements, focusing on strengths rather than limitations. So making sure tic presentation is just one aspect of who they are. It's really important to balance, because tics can take over. It's really important to balance that off with focusing on their strengths, encouraging a positive mindset to build resilience. Empowering your child. So this is involve them in the decision making about their care, build up their self-advocacy skills, enable them to have the confidence to express their needs and preferences, encouraging activities that boost self-confidence. So if we understand how their environment interacts with their tic presentation, so engaging in sports, engaging in musical activities. So I work with young people who actually play musical instruments, and during the time in which they play musical instruments, again, there's no tics, and there's no tics for a certain amount of time after. But it's not just active participation in music, it's also passive. So listening to certain types of music can be found to influence tic suppression. So it's finding out what works for them so that they can manage tics on their own as well. Avoid drawing attention to tics. So help your child feel more comfortable in social situations by avoiding drawing unnecessary attention to their tics. That can be incredibly hard, but even negative impact of tics and other people's responses to them can be really, really challenging and is associated with increasing tics. Going and actually supporting them and giving them a big hug if they're really struggling with it, that itself is also associated with an increase in tics. So the best approach is to take a neutral approach, is to not draw negative attention nor necessarily positive attention to the tics as they happen. So it can be really challenging to not want to go and hug your child if they're distressed, but after having education and awareness and an agreement of this is how I will approach it, is to not draw as much attention as you possibly want to, can have a really positive impact. Establishing routines. So consistent daily routines makes life more predictable, adds more structure, can help reduce anxiety and stress, which in turn can minimize tics and intensity. So resources that can be accessed, which hopefully, I think as this is being recorded, will be able to be accessed. So Tourette's Action is the leading organisation in the UK to supporting families and schools regarding Tourette's. They have loads of resources. Great Ormond Street is perhaps the leading centre for treatment of tics in the UK and have a massive research part of their remit. Then an American one, the Leaky Brakes Toolbox, has got lots of nice videos in there as well that can be really helpful for young people. And there's a great book called Nix Your Tics by B. Duncan McKinley is recommended. And thinking from a school's perspective, because actually schools are one of those environments that young people can really, really struggle with. So it's really important that working collaboratively with teachers and schools to ensure that that environment is as appropriate as possible. So helping teachers understand what tics are is absolutely crucial. I've worked with young people who have tics and where they've been told off for the tics. That sort of negative reinforcement only goes to make the tics worse, and also sets an example for the rest of the class as well, that these tics are bad, and we're trying to move away from that. So trying to get them to understand that is really, really important. And the fact that, you know, up to 20% of young people at school age experience tics, it's really important. I mean, that's a really big minority of young people to have that sort of support. And it has a massive impact on their ability to access the curriculum in education. It's disruptive. It can be, especially the motor tics. So maybe placement in a classroom is really important. So perhaps it's less disruptive or less noticeable by others. How it can interact with people's socialization in school. If there's a negative connotation associated with the tics, that can have a massive impact on young people's ability to make friends and maintain friendships. It can have an impact on their academic performance. If there are tics that involving hand tics, if they don't have additional time to work, then that can have an impact on tests and exams. And all of this wrapped up can have a big impact on their emotional well-being and self-esteem. And we know that having low self-esteem, high anxiety, is associated with an increase in tics. So all of these things can potentially impact and maintain tic presentations. So educating staff is really, really important. Now, some people may have children who go to schools that have a mental health support team, the MHSTs. I know that the mental health practitioners within the MHSTs are currently undergoing training to support young people with tics and Tourette's in school. So hopefully for young people at schools, they can get support in school, which is absolutely critical for their support in the wider services. They can also get individualized support if there's a SENCO or other highly trained teachers who can help them. That can not just be tics, but also thinking about low mood and anxiety as a result of having a tic presentation. Classroom adjustments, so where you sit in the classroom, being less distracting. If they're loud or the tics are frequent, it's really important that they are situated in a place that they're comfortable with, but also means that they feel that they're less distracting to other people. So promoting awareness. So this isn't just within teachers, but this is actually within classrooms themselves. So being able to support classrooms, pupils to understand what it is about tics and to help promote a more inclusive culture. Peer education is so critical in this because we know that friendships are super critical in schools. And actually, if you don't have your peer network, your support network, then that can be really, really tough. Implementing something like a buddy system, whereby perhaps a young person who experiences tics or someone who perhaps has experienced tics can be really, really positive for a young person. And then wider support networks. So schools having networks of groups for young people who have tics and Tourette's, clubs, just being able to be with young people, to destigmatize, it's not just me, actually there's lots of other young people who experience these difficulties, can be really, really useful. So I am mindful of time. I went over slightly what I was supposed to. I hope that wasn't too boring or lengthy or anything. I'll stop sharing. I hope that was useful, but I really, really am interested in answering any questions you might have and having a little discussion in the time that we do have left.
Thank you so much. That was wonderful. A sort of a note that I did jot down was thank you so much for acknowledging the challenges, but also recognizing that the pathway is going to be really a positive change.
I
as
hope
well.
so. And the fact that we're working together with GPs and pediatrics to create a pathway so that we don't have this bouncing around, because I find it really, really upsetting when young people's ability to access support is delayed through these sort of process issues. We're kind of fighting a little bit because there is no national guidance, which always makes things a bit more difficult. With regards to schools, though, I think it's great that schools that have a mental health support team are being trained up to support young people in the school environment, which is absolutely critical. Because if you can create a situation, an environment at school that's inclusive and supportive, it has a huge impact. I've had to go into schools and speak to teachers, speak to classrooms to try and create an environment that is much more acceptable for young people with Tourette's, because it can be really, really distressing. And we know that distress causes and maintains tics. So it's about creating that. Anyway, I've talked too much. I could talk on it all day, so I apologize. But are there any questions,
Thank
Emma, that
you.
would be helpful for me to go through?
So I've got one in my inbox. Oh, no, two. And if anybody else wants to add, oh, here they come. They start flying in. Is CBIT still applicable for moderate or severe cases, or would you skip straight to the latter stages of the pathway?
CBIT is very much, I would always start with CBIT. And although there are no national guidelines on doing this, the research would suggest that CBIT actually is a really good starting point. What I would do, and this is how I've worked historically, is you start with something like CBIT. Most young people respond positively to it. Some don't, and I would use a slightly different technique called exposure response prevention, ERP, and I'd flip over to that because some young people respond better than that. If they respond to neither, then I would escalate and would think about medication as a potential for sure. But yeah, I would definitely always start with CBIT as it has the best evidence base for helping for these more moderate presentations.
Thank you. Thank you, Lou. Lou says, thanks, Michael. Great talk. My daughter itches her legs and now this has stopped. She now blinks. Is leg itching seen as a tic?
Potentially, I guess if we're thinking about the what's, if you remember, I was talking about premonitory urges. It's what's driving that. Is there a physical sensation in the body? Then potentially yes. I guess it would always be good to check out whether there's not a physical reason why she's itching. Is it something like an eczema or an allergy? Worth checking. But if it's more of a sort of a muscular feeling, then it's probably more likely to be a ticking sensation. But you mentioned it's moved on to blinking. This is one of the complexities with tics, is they tend to transition and move quite a lot. So if I'm working with a young person over sort of 8 to 12 weeks doing CBIT, I will see often lots of new tics emerging. I'll see some tics disappearing, some becoming more severe. So tics itself tends not to be fairly stable. It can be, but often you'll see it come and go, new ones arriving, old ones disappearing. So there's a lot of variation. It's very diverse, the presentation. So I would keep an eye on the tics for sure. The blinking is a classic tic. So I would keep, no pun intended, I would keep an eye on it just to see. Be interesting to see how long she's experienced some of these tics for. But if it gets to the point of experiencing it for 12 months, there's like 2 motor tics and a vocal tic that potentially go down the route for a Tourette's diagnosis. But just be mindful that often tics can come and go. But what we're really concerned about is those consistent presentations going forwards is really important. I hope that answered your question.
Thank you. Can you give some ideas around what to say to a parent whose child is up all night with tics?
Okay, so that's really, really tough. And I guess I'd be thinking about the environment and the triggers. So I would want to have a think about what it is about that environment at night that are triggering them. So thinking about the environment, who's around, what they're doing beforehand. If you remember, 90% of people who watch TV or play games have noticed their tics have increased. So it's thinking about those activities and those contexts that encourage tics. And is there something that can be done instead? So could we be encouraging different activities at night that are more associated with lower levels of ticking? And also thinking about the mum's reaction to the tics. As I mentioned, it can be really understandable to provide them lots of support, lots of love, to try and help them, support them. However, if you react to a tic, a young person having tics, be it negatively or positively, it's often associated with an increase in that ticking. So even if you're being really compassionate and loving, what tends to happen in your mind, and this is that sort of behavioral type psychology, what can become habitual is the young person associates ticking with receiving this love and affection. So what's a really good way of receiving that love and affection is to tick. So there's no reason for them to reduce their ticking, because if they tick, they know they're going to get all this love and affection, which they may well be wanting. What might be is thinking about how their response is and perhaps trying to be a little bit more neutral over time and unwinding some of that association. So think about the context, the triggers, thinking about activities that may be more associated with reduced tics, thinking about the way that she's responding to a young person with tics, and maybe trying to, and it's really tough to do so, adopting a more of a neutral stance, because a neutral stance is more associated with lower levels of ticking. I hope that's helpful.
Thank you. Thank you so much. My son has a tic at the moment where he screws his eyes. This is hurting him. What habit reversal could be used?
So eye screwing is a really, really common one. So I guess I'm guessing, based on your description, I'll take my glasses off now, I can't see anything, you're sort of talking about that. So what I would do is, if you think about what a competing response is, you want a response that blocks doing the tic. So if someone is screwing their eyes, what they might want to do is gently open their eyes a little bit. So it's kind of the opposite. And actually, when you're opening your eyes a little bit, it doesn't have to be massive. It's just about engaging those muscles, opening them, holding it until that urge goes. So it's about engaging an activity that blocks, that is not particularly noticeable, and you can hold until the urge goes, or for a minute. That is worth trying. Now, the important thing is, and this is the way I work with young people, is you can send them off with homework saying, okay, let's work on this competing response. They go back and they can come back and say, no, it doesn't work for me, for a range of reasons. So you may need to play around with it a little. The important thing is, it's the three conditions are: it blocks the tic. So by opening your eyes a little more, you're preventing someone from closing their eyes. It's not particularly noticeable, and you can maintain it for a little bit, until the urge goes. Give that a go, I would say. I think online, I think maybe Tourette's Action, there may be like a catalogue of competing responses associated with typical tics. That might be quite helpful for you in just exploring some of these other options.
I can imagine with age as well, it's all down to motivation as well.
Oh,
The young
yeah.
person isn't wanting to make those reversals. That
Yes.
would be quite hard, I think, with anything like this.
Yeah, so this is where the psychology can come in really bad, because that sounds terrible. Encouraging behaviors using positive reinforcement is really key in working with the younger people. So for teenagers, those who've hit puberty, a little bit older, often their motivation is about not looking awkward or feeling embarrassed amongst their peers. Their motivation levels are generally quite high, because the sort of social threat of being seen as looking a bit odd or being embarrassed is really high. So they're motivated to change. For younger people, where that sort of social threat isn't perhaps so important, is where I bring parents in more often than not. And we kind of use positive reinforcement in psychology. These are things like reward charts. The number of times I speak to a young person and say, okay, what do you really want? What would be really helpful in motivating you? They'll inevitably say money. And obviously we have to have a discussion with the family about this. So it's finding something like reward charts you have at school is really helpful. And often I'll work with parent and young person so that we have an agreed arrangement so that when the family at home, they know what the young person's supposed to do. And whenever the young person does a competing response, they are rewarded for it. And that's called positive reinforcement. So we're kind of using psychology against the tic formation, kind of unwinding it. So parents are really key. And I don't want to say the word bribery because it's not bribery, it's positive reinforcement, but it's really important just to find something that will really incentivize the young person.
Oh, I'm a
And
parent of 2 children. I bribe.
okay, fine.
No shame.
I'm not sure in my official capacity in CAMHS I can say bribery. However,
From a parent carer perspective, oh no,
yeah,
that's my life, literally. Thank you.
no worries.
This next person, I think you've answered it yourself, my lovely.
Oh,
My
okay.
4-year-old selective mutism and autistic young person blinks when anxious, licks her lips, raises her eyebrows. Should I do anything about these tics? They happen when she's anxious, so I guess supporting her with the anxiety is actually where it's needed.
Yeah, absolutely. So I guess it would be important to know how long they've experienced these and again whether there's like 2 motor tics and if there's any vocal tics in there. I think if I remember correctly, say there was a diagnosis of autism as well.
Yes. Yeah.
So I guess maybe thinking about, is this a tic? Because remember I mentioned about stereotypies, and actually autism is one of those conditions where you see these repetitive behaviors that isn't necessarily tics or Tourette's. So there may be a sensory component in that, especially the licking of the lips, and just thinking about what it is they're getting out of it. If it's the feeling, then actually substituting that activity with something else may satisfy that sensory feeling. But those types of repeated behaviors aren't quite Tourette's. Could be, and you can have a combined diagnosis of autism and Tourette's. But the reason why they're doing it may not necessarily be this premonitory urge. It could be just feels really nice. And then it's about thinking about, is there anything that you can do that satisfies that sensory feeling instead? So monitor it. If it continues, if they start to diversify and intensify, then go to the GP. Hopefully they'll do something like a physical health screening. If it's causing not much, I've just realized it's 1 o'clock. It's not causing too much difficulty, I would definitely recommend speaking to Tourette's Action. If it's getting in the way a little bit, especially as she grows up, then hopefully a referral into CAMHS would be the way forward.
Thank you.
It's okay.
Have we got one more?
Yeah, go for it.
Yeah, thank you. Tic attacks. Our daughter has been getting stuck into the loop for 30, 40 minutes with multiple tics. Really hard to watch. Is there anything else we can do in the moment to help?
I guess it would be really important to understand what those triggers are and thinking about what techniques there can be. So during those attacks, thinking about what diversionary tactics you can do, what activities that she can engage in, if she can engage in them, that are associated with reducing tic activity. So these would be activities that really capture her attention. So that sort of thing, or exercise, again, can be really beneficial for reducing the levels of tics. So thinking along lines of that, and I guess thinking about tic attacks, I guess this could be, and I don't know, I'm not familiar with the cases, thinking about what precedes the tic attack. Is this a suppression at school environment, for example, and then these tic attacks emerge when she gets home? If that's the case, then it's about thinking about working with school to make the school environment more acceptable for her to express some of those tics in that environment. So it's creating a more inclusive environment. So if she is suppressing, then what we wanted to do is perhaps not suppress so hard, because maybe then she won't be rebounding so hard in that environment. So yeah, it's very difficult without understanding the individual case. It's very complex, and this is why we go through this process of formulation, of understanding all of these triggers, understanding what helps, what supports. So, but working with, if it is a rebound thing from school, definitely speaking to school and seeing what can be done to foster a more supportive classroom environment might be really helpful. It's difficult
Thank
to
you.
say, unfortunately, without knowing more detail.
Thank you. Thank you so much, Michael. I have got more questions in the chat box, but I did just request for Michael. We only had him for an hour today, and we're
I
ever so
know.
grateful. And the big takeaway I have to say for me was the stereotypies. Actually, that was
Yeah,
big difference of information for me. Thank you, Michael. I really appreciate you coming on today.
my pleasure.
I thank you so much.
It was lovely. You take care, and
Thank you.
everyone has a lovely day. Take
Thank
care.
you so much.